Good morning, and thank you very much for your contribution to orthopedic outreach, and also a good morning to all those who are elsewhere in Australia listening to this. Why talk about disc prolapse? Disc prolapse is a problem which you and we as surgeons share very much, and I thought it was worth bringing up again and talking about a few things. As you know, whilst we talk about prolapse, many people talk about those other terms: protrusion, rupture, herniation, and the like. Interestingly, the word herniation is the one which seems to get the biggest payouts if it becomes a medical legal term, but actually they're all a continuum of gradual rupture of the annulus fibrosus, which normally contains the softer material inside the disc, so that gradually part of the center of the disc, called the nucleus pulposus, comes out and then starts, in some cases, irritating the nerve roots. The prevalence is quite high, so they say that between 1 and 3% of people will actually experience this, slightly more in males, and usually in the active part of life. Just out of interest, who in the room has actually had sciatica? And I count myself in that as well, and I don't know whether we conform with that percentage, but it's a very common problem. Now, unlike talking about famous sportsmen, I'm going to tell a little true story about a tradie, and you can all substitute the story which you remember of a recent patient, because I'm sure you've got somebody with a similar issue. The carpenter, in this case a 33-year-old man, injured himself at work whilst lifting a compressor. And so often patients give us that story that he felt something go in his back and he felt an electric shock going down his leg. It's a very common description of what happens then, but not actually yet sciatica. They just continue working a little bit confused, a little bit cautious, as did our man here. Next morning, he had great trouble getting out of bed. Now, many people have these kind of stories with some pain, which is then worse with bending, but also many people have a cupboard at home which contains tablets, and the people then resort to either their own or possibly, in his case, to the tablets of his wife, and he tries to get to work and he can't get out of the car because gradually with activity all this gets worse, and he then develops numbness in the foot. Now, he quits work and goes and sees a physiotherapist, because in our current system you are of course very often the primary carers for many patients. And with that comes a responsibility, because not only do you have to look after these people, you actually often also people who have to make a diagnosis. You are not only physiotherapists, you're also psychologists, because a lot of these people come with anxieties and worries, and you're a trusted profession. You care for both body and mind. So he comes very worried with his pain, also as a tradie worried about his future, because now he's experiencing progressive symptoms going down his leg, and you must know many of these type of stories. What can you do? Well, you give some physical relief. They often have muscle tension, they are stiff, they don't know how best to move, and you give most of all reassurance, because the prognosis is actually very good for an acute disc prolapse. The responsibility is also to be reasonably certain that you're dealing with a disc prolapse, because these people have seen you first before everybody else. The story tells a lot. Remember, neurogenic pain is often described as being progressive. Now, I'm not only talking about lumbar discs. The similar story is for the cervical disc, so there will be pain down the arm or pain down the leg from central to distal, sometimes worse with posture, often associated by abnormal feelings, or we call them paresthesia or numbness, ants running up and down the leg, hot and cold. Some people describe it as a toothache in the limb, and it can be quite debilitating. And in a schematic fashion, it's not difficult to understand that if you have a prolapse hitting a nerve, then there will be discomfort in the region of the nerve, But why the delay? Why not on day one? Because an inflammatory process is actually what causes the pain, and that often takes a couple of days to develop. Numbness is early, but pain is usually delayed by a couple of days or longer. And the same thing, of course, in the lumbar spine. So in our typical story, fortified with hot packs, our carpenter goes home, he has some gentle exercises, which are really postural, because we're waiting for Mother Nature to do her good work to relieve the pain. What happens? Common misconception is the disc slips back in. It doesn't slip back in. It can't slip back in because all the forces are there to push it out, but the fragments often shrink and the inflammation settles, and that is what we wait for to relieve the pain. Patients are advised to rest, but only for a short period. We shouldn't have bed rest for longer than a day or two, and gradual and gentle activities. Our tradie tries to return to work but gives up. That means he now starts getting financial worries. And a very common question in our community is, should I have an injection? Almost all patients want injections. And do they help? We're not sure. I'll come to that. And the next other question is, when should we scan? Considering the natural history is very favorable, is there any point in scanning early? Well, you need to scan if you're not sure of the diagnosis, or if you're worried about red flags, tumor or infection, unusual presentation, sick patient, long history. Yes, you need to refer these people or get a scan. Progressive weakness is something which worries us, especially in young active people, because we cannot miss the boat. It's very difficult to undo weakness. Bladder and bowel dysfunction is something we talk about, the cauda equina syndrome. That is rare but very severe. Failure to improve is another reason to scan, and of course in those people who have such severe pain that no matter what we do or what you do, they cannot cope. The MRI is the gold standard. It shows soft tissue, not only bones. So it shows our discs and it shows our nerves in detail, and it shows the CSF, which is actually to be seen like spare room in the spine. And so it shows is there enough or not. Doesn't involve radiation, but it's expensive, and a few people are claustrophobic, and occasionally people can't have it, such as those who have a pacemaker, because old pacemakers are not MRI compatible. Here, for instance, you see quite a large disc prolapse on the left side, and it's not difficult to imagine how the patient had leg pain. Occasionally, we have a diagnostic dilemma when we have two discs prominent on an MRI. A CT scan, modern CT scans can show a disc. As you know, our federal government is trying to stop GPs from ordering MRI, so many patients come with a CT scan, and if they have a good CT scan like this one, again, it's not difficult to diagnose, and if that concurs with the patient's symptoms, there's no need to have an MRI as well. And for those who like historic things, here is actually a CT myelogram where a dye is put into the CSF, and you can see on that right side there is what's called filling defect, which represents a large disc prolapse. But not everything which causes leg pain is necessarily a disc prolapse. In this case, we see quite a large synovial cyst. There's no way of distinguishing that diagnostically from a disc prolapse. It causes the same inflammation and pain down the leg, and the MRI is very good. In this case, in the cervical spine, there's a large epidural abscess, and so the MRI is fantastic in that case. Some patients with spinal stenosis can present with unilateral leg pain, which is exactly like that of an acute disc prolapse. And discitis, a rarer condition, again can present very similar. Back to the injections. What is actually injected? Well, it's a bit of local anesthetic with various forms of cortisone. Cortisone is a strong anti-inflammatory, and don't forget, it's also a euphoriant. So patients will get a little bit of systemic cortisone and will feel much better with that. It can be used diagnostically if one's not sure which nerve root's involved, and it will give short-term relief. I say to patients it gives 50% relief to 50% of patients and not much more. I use it occasionally when there's severe pain early in the episode, when we're not thinking about surgery but the patient can barely cope, and occasionally can be repeated. But it's probably overused in our community, and now at the end of every CT or MRI, the radiologists are suggesting, if clinically indicated, a steroid injection can be given, which is a form of marketing of their practice. What do they look like? Well, here's a transforaminal injection, which of course has to be given under CT guidance, which is why the radiologists are interested in that. In our not so typical story, because our patient is not getting better, he is becoming a little angry and his debts are increasing. He has finally an MRI at 3 weeks, which shows a disc prolapse at 4-5. So then the next question is, when to see a surgeon? And that's actually a decision which is made not by the surgeon, it's made by the patient usually. Sometimes patients are referred to confirm the diagnosis, sometimes because they are desperate, sometimes because they're impatient. But in fact, there's no need to refer early. We only need to refer when we've actually run out of the usual time frame, which will be somewhere between 4 and 6 weeks after the onset. There are very few absolute indications for surgery. One is the cauda equina syndrome. One is if there's progressive weakness, significant weakness, so that actually people have difficulty walking. Sometimes when people haven't improved after, say, 6 weeks. And of course, we always need to have signs, clinical signs and scans which correlate. But ultimately, it's always the patient who decides. Discectomy is still a very good operation. And by the way, the term microdiscectomy is thrown around a lot in our community right now. And the microdiscectomy actually doesn't mean a small discectomy. It means a discectomy done with a microscope. But in our community, everybody just wants a microdiscectomy, even if it's a very large disc. Of course, you need to remove what is there. We need to check the level with the X-ray, and magnification helps. We remove the prominent disc material and decompress the nerve. A common question is, how much do we actually take? A big disc prolapse is only about 1 to 2 mils and represents perhaps 10 or 20% of the disc. And what is the material? It's quite firm, fibrous material. Sometimes, like in this case, a surgeon can be lucky it all comes out in one, but often there are many fragmented little pieces. And by the way, this is a slide of how not to do it, because there's absolutely no need to put staples in the back, which are very uncomfortable. We have small incisions with absorbable sutures, and the outcomes of discectomy on the whole in a well-selected group are excellent. Takes about an hour. Most people stay overnight, although some could go home the same day. They stay cautiously active for a couple of weeks, and in the first period, I don't send them back to you. I send them back to you after 10 days, after I've checked their wound, and then we start with a core strengthening program, range of motion, gradual increase, and depending on the type of work people do, they will gradually go back. And our patient did opt for surgery at 5 weeks. He had a discectomy with a decompression of his L5 nerve root, and his leg pain was relieved as soon as he woke up. Yes, he had a bit of back pain from the incision, but that was minimal compared to his leg pain. And even though he's a carpenter, he was back at work at 2 weeks doing light work, but he was in charge of what he could do. Sometimes surgeons face particular challenges, and as tattoos in the lower part of the back are becoming common, we have to start placing our incisions in places we wouldn't otherwise choose. We have questions about sport, and the majority of sportsmen return to sport, and good studies have been done. Not quite full activity, 60 to 80% of their colleagues, so some restrictions will remain, and I'm not sure whether that's due to pain or actually due to caution. Recurrence rate, unfortunately, is high, with a 5 to 10% in their lifetime. And rarely, but again, because it's such a common condition, there are patients who have progressive back pain because of their disc degeneration. In the neck, all this also happens. The neck actually has a better chance of improving, but is slower to improve. So those people with arm pain, again, have to be counseled. That may take up to 3 months to settle. Occasionally, a collar helps. And of course, cervical surgery is, on the whole, more complex and more risky. Core strengthening, I don't have to tell you how to do that, but very popular right now is Pilates. Swimming helps. I get patients to choose something which they like, because if somebody doesn't like water, you can't make them get into the water, and vice versa. Improved posture and work practices, of course, help. Unfortunately, chronic pain is in the background, and we talk about a window of opportunity. When should you have an operation? Don't wait for a year. In a very broad sense, there's a window of opportunity between 6 weeks and 6 months. Thereafter, there's a risk that that leg pain leaves an imprint somewhere in the brain where we process all these things, and depression is not uncommon. In our community now, we have analgesic dependence, which is another problem if one waits too long, and social disintegration when people lose their jobs or lose their boyfriends or lose their spouses. The cervical and lumbar discs are frequently injured. I do point out that the spine is an emotional organ, and that's why it requires not only physiotherapists, but you as psychologists. There's a lot of fear and misunderstanding. The old wheelchair paranoia, if I don't do something, I'll end up in the wheelchair, which is really a myth. It mostly has a very good prognosis and can be well managed with your help and with time. Thank you very much.